I'm Louisa Baldini, and I am delighted to be moderating this panel, The Children of the Frontline, in partnership with Save the Children. 1 in 5 children worldwide live in areas affected by conflict today. Over 100,000 children have been killed and maimed in conflicts around the world since the UN started tracking those numbers 14 years ago. In the 5 deadliest conflicts for children in 2017, Save the Children analysis of UN data shows nearly 3/4 of all child casualties were caused by explosive weapons. This panel will look at the latest trends in healthcare provision for children in conflict and will formally launch the French translation of the world's first paediatric blast injury field manual produced by Save the Children in partnership with Imperial College London. And both are represented, in fact, on our panel today. We'll also get an update on a new political declaration led by Ireland to address the devastating effects of explosive weapons in conflict. So let me introduce our panel. We are joined by Dr. David Henson, who works at Imperial College in London in the Department of Bioengineering on prosthetics technology. In February 2011, when David was in the British Army in Afghanistan, he lost both of his legs due to an IED, an improvised explosive device, and has had to completely readjust his life. He's also the Veterans Advisor to the Centre for Blast Injury Studies. We're also joined by Dr. Michael von Bertele from the University of Southampton in the UK, where they have a programme called the International Blast Research Network. He's also a former humanitarian director for Save the Children. We're also joined by Alma Tazlijan Al-Osta, Protection of Civilians Advocacy Manager at Humanity and Inclusion. And last but not least, James Denslow, who is head of the conflict team at Save the Children. Welcome to all of you and thank you for joining this panel. So James, I wanted to start with you. What is the latest data that you can share with us from Save the Children?
Thank you very much, and good afternoon, everybody from the UK. It's good to be on a warm-up panel ahead of Morgan Freeman. And the latest data, unfortunately, to answer your question, is not great. But first of all, let me introduce myself. I work for Save the Children as a humanitarian and child rights movement that works across 117 countries. And I'd like to thank Sultana Aftal and all her team at WISH, responsible not just for putting on this important summit in such testing times, but also for being such a constant champion of innovation and partnership when it comes to the protection of children in conflict. As you will all know, WISH is a global healthcare community dedicated to capturing and disseminating the best evidence, practice and ideas. I first attended the WISH Summit back in 2018, where we spoke to a huge range of health actors from across the world about the then nascent subject of paediatric blast injury. And as was mentioned, according to research that we commissioned, we're seeing today some 426 million children living in conflict-affected areas of the world today. The conflicts that they're seeing are becoming more protracted. Next year, for example, will mark the 10th anniversary of Syria's war. Conflicts are becoming more complex with far larger numbers of non-state actors involved. And conflicts are becoming more urban, as with the trend that we'll see some 68% of the world's population living in urban areas by 2050. So in short, the front lines of modern conflict are no longer some distant horizon filled with soldiers of two warring sides. Increasingly, the front line is the homes, schools and playgrounds of children. From Syria to Yemen to Afghanistan, our field teams are meeting children who have suffered life-altering injuries caused by explosive weapons. We know now more than ever that children are particularly vulnerable to these effects. Their bodies are thrown harder and further by the blasts, their bones bend more, increasing the chance of long-term deformities with little chance of recovery. They have less blood to lose. They are unlikely to receive the specialist medical care they need, with health systems often at the point of collapse and fewer trained surgeons available. So although improved care of the adult blast injury casualty in the last decade has transformed survival rates, currently there is no consensus about hemorrhage control in the child patient. There are no tourniquets designed for children, few child-specific transfusion protocols, and current research is clear that children with blast injuries are therefore considerably more likely than adults to die at the point of wounding. Furthermore, children are often injured in groups, so even if they survive and are admitted to hospital, such severe and complicated forms of casualty requiring immediate and simultaneous treatment in numbers can overwhelm existing medical capabilities. And that's a good reason why killing and maiming of children in conflict is defined by the United Nations as a grave violation. If children do survive explosive weapons, they often find themselves dealing not only with the physical trauma and disability, but the loss of family members, the destruction of their homes, and the disruption of their education, and along with it, their future prospects, to say nothing of the acute stress caused by growing up in a war zone. Now, I think we all know just how resilient children can be, but we cannot expect them to recover without sustained and specialist support. Left untreated, we know that the long-term effects of blast injuries, both physical and psychological, will leave children facing a lifetime of suffering and a whole generation lost and at risk of exclusion. To better understand the effects of explosive weapons on children, the Paediatric Blast Injuries Partnership, a coalition of medics, academics and NGOs, formed with the co-hosting from Save the Children and Imperial College London. In April of last year, the partnership piloted the world's first ever field manual on paediatric blast injury, co-authored by specialists across the relevant disciplines, with medical partners in the north of Syria. It's estimated that 1.5 million Syrians are living with permanent war-related impairments, with 86,000 people, including tens of thousands of children, whose injuries have led to amputations. The field manual is a comprehensive guide for local non-paediatric specialists who are often forced to operate on and treat children with blast injuries with little or no previous experience or training. It provides healthcare workers in conflict settings with knowledge and practical advice on the entire continuum of care, from the point of injury to treatment to rehabilitation and mental health support. And I'm now proud to say that it's in the hands of medics in 12 conflict-affected countries and is being translated into Dari and Pashto. Last November, in Qatar, with the help of WISH and its networks, we were able to launch an Arabic translation of the manual, and today I'm pleased to officially launch its French translation. Although COVID-19 has delayed some of the next steps for the partnership, we do hope to forge ahead with work on a digital version of the manual and resources for non-medics who come across blast-injured children. There's also the track on data and systems that Michael von Bertele can talk to, operational research across academia, such as that Dr. Dave Henson can speak to, and efforts to make sure that we address the upstream causes of this issue through a political declaration that Alma from our partner Humanity Inclusion can speak to. The Paediatric Blast Injury Partnership is a community of concern that's always open to new members and ideas, so please do get in touch if you or your organisation has something to bring to the issue. I look forward to reporting back on more of its successes, hopefully face-to-face at WISH 2022. Thank you very much.
James, thank you, but obviously you're not going anywhere because you are going to answer some of my questions and some from the audience as well if they come in. So thank you though for that overview. And you mentioned some data that Dr. Michael von Bertele has. Doctor, would you care to share that with us, please?
Yes, the first thing to say is that one of the aims of the partnership has been to improve the quality of the data that we have available to us, because it would be fair to say that the important and valid data that we have at the moment comes from those children who have survived and been treated in what I could describe as first world medical facilities. We have an interesting set of data that the Americans collected in Afghanistan over a 10-year period of all of the children who've been admitted to one of the American field hospitals. That's nearly 3,500 children over a 10-year period. And there's some very detailed analysis of the care that they received and the complexity of it. And what it really highlights is that children injured in conflict, more than half of those children had been injured by explosive weapons, a quarter by gunshot wounds. What it highlights is that the care requirements are very high indeed. Treating casualties of conflict is a complicated business. But the children who were admitted to those hospitals, they made up nearly 1 in 10 of casualties during that period, required an enormous amount of support. They required intensive care, they required repeat surgeries, and they took up almost twice the resource that an adult casualty would require. Now, it would be wrong to call those the lucky ones, but they were the survivors who made it to a first-class medical facility. What we don't have is much data on those who didn't make it to those facilities. There's an interesting piece of work done this year by Radboud University, who looked at nearly 4,000 children who'd been admitted to Red Cross, International Committee of the Red Cross hospitals over a 20-year period. And although very little data was captured, they used a comparative method to see whether the Red Cross classification of wounds classification could be used to assess the treatment needs of those children. And again, they found there was a very high correlation between what was described, the complexity of injury, and the resources required to treat them. But what that tells us is something that instinctively we know. Children who've been injured by these weapons require an enormous amount of clinical intervention. And what we also know is that is often not available to them. And so what we hope to do within the partnership this year was bring together all of the organisations that are involved in delivering care in those conflict areas, particularly the International Committee of the Red Cross and organisations like MSF, and ask them to collaborate in some field work to look at not just the care that was being given to children at the time in those facilities, but also to try and understand what aftercare they would receive, because we have almost no information on the follow-up care that those children have received. And yet we know that having been initially treated in a medical facility, their aftercare may last for many months, probably many years, and for many of them for the rest of their lives. And there is almost a complete gap in our knowledge about what happens to those children who have been injured, even those who've been admitted to first-class medical facilities, but those who have just been treated by local medical facilities where they have no access to specialist paediatric care. That's a big gap in our knowledge, and that's something we would really like to address.
Thank you very much. Very sobering thought, that. And now, David Henson, I wanted to ask you about the research that you're doing at Imperial College. What interesting findings can you share with us from that?
Thank you, Louisa, and good afternoon, everyone. I'll talk through a little bit about our research direction at Imperial College and use myself as a sort of personal example in this. So I come from a military background, and I've seen firsthand the effects of war and conflict on all who get involved with it. I'm also an unexpected survivor. I stood on a bomb in Afghanistan, which resulted in me losing both of my legs above the knee. I shouldn't have survived. My life was saved through proper and immediate trauma management within the first 10 minutes of injury and the expertise in the critical care period over the next 7 days. Now, as a consequence of these injuries, I was given rehabilitation from a multidisciplinary team of experts, and I learned to live, I learned to walk, and I learned to run. These lessons were hard learned, and many of my predecessors did not survive similar injuries, but medical science progresses, such as has come from our own Centre for Blast Injury Studies. Now, Imperial College has been researching blast injuries, particularly in the military population, for over a decade, firstly within our Imperial Blast programme and progressing to the Centre for Blast Injury Studies. Our unique engineering and clinical collaboration results in real benefit to patients, including changes to the way in which armed forces personnel are compensated for their injuries, improving limb salvageability through instigating changes to PPE, and saving lives through changes in guidance on the use of things such as pelvic binders, for example. Within the Centre for Blast Injury Studies, one of the clinical priorities is a focus on extremity injuries and amputation. As the research at Imperial and within the centre has continued, our focus has also expanded, with Save the Children forming the Paediatric Blast Injury Partnership, and as James has said, the development of the Paediatric Blast Injury Field Manual, which enables first responders to understand the critical differences in the treatment of blast injuries in children. The NIHR Research Group for Post-Conflict Trauma was also formed, and this research group focuses on lower extremity limb salvage and reconstruction, primarily concerning injuries caused by explosive weapons, but expanding to include those caused by gunshot. Whilst our primary aim is the development of surgical and regenerative medicine techniques to prevent the requirement for amputation, sometimes this outcome is inevitable. So our focus on the treatment of extremity injury naturally progressed to the development of prosthetics, with our research group developing a low-cost prosthesis that meets the specific requirements of the through-knee amputee, which is a preferable surgical option in low-resourced environments. Now, our work in these areas has led to the expansion of the strategic objectives of our post-conflict trauma and prosthetics program to create a specific focus on lower extremity injuries in children. In conflict or post-conflict zones, legacy weapons of war, such as landmines or improvised explosive devices, indiscriminately injure civilians, and children are particularly susceptible to these legacy weapons of war due to their natural curiosity during play. The child amputee is particularly vulnerable to multiple amputations caused by blast. Of 9 paediatric patients brought in simultaneously to one medical unit in Afghanistan, 3 suffered from triple amputations and 5 had double amputations. 20 to 29% of landmine strikes on children lead to amputation. The effects of blast injury and amputation on children are very different to the effects on an adult. The closer proximity of the torso to the blast brings more widespread injury, and the effects of amputation on a growing skeletal system bring additional problems for prosthetic fitment and a frequent requirement for multiple revision surgeries. Pain and pain management in the blast injured child is poorly understood, as is the effect of injury on the long-term mental health, regardless of injury context. The social effects of amputation in unstable and insecure environments where violence is fluctuating and ever-changing renders child amputees particularly vulnerable and often unable to access any form of care or support. In 2016, there were more than 375 million children living in a conflict zone. We are expanding both our extremity salvage and reconstruction work to ensure the best possible chance of limb retention for children injured by conflict or other extreme trauma in the low resource setting. And where this is not possible, ensure that they have the best possible prosthetic solution that enables the child to engage in education, access healthcare and aid, and escape the poverty cycle that is so often surrounding disabled individuals. We will develop prosthetic solutions for children that can be rapidly deployed and delivered in conflict-affected areas, enabling essential freedom of movement, and prosthetic solutions for children in low-resource settings that enable growth of the prosthetic with the child, reducing the demand for access to prosthetic services, a key barrier for mobility development. It's an unfortunate reality of war that children get caught in the middle, and I've seen it with my own eyes. As a priority, we must protect our child victims of war. This means providing the best possible treatment at the point of injury, and where amputations are inevitable, providing children with prosthetics that grow as they themselves grow, allowing them to run, skip and play, which are things that every child should be able to do. Thank you.
David Henson, thank you very much indeed for your unique perspective, both personal and professional. And to Alma Tazlijan Al-Osta now, you work more on the advocacy side. So I wanted to ask, there is a political endeavour behind the scenes, most notably an Irish-led political declaration. Can you bring us up to date with that, please?
Yes, of course, there are various legal instruments and policy frameworks that are calling for better protection of civilians in conflict. And in our view, there is a need to strengthen the protection of civilians, and political solution exists. And that's exactly the political declaration that you have just mentioned. The current development of an international political declaration is a necessary and an achievable step to strengthen the protection of civilians in urban warfare, especially children. Based on the information that we and our partners, such as Save the Children, have been gathering since the last 10 years, we have recognized that the use of heavy explosive weapons in populated area is a major humanitarian problem which causes a distinct pattern of harm. And this pattern is something that is worrying us so much because it's reoccurring in almost all the conflicts in the world. And this is what is this political declaration trying to target and will target at the end. I would like to just share a few thoughts about the devastating impact of explosive weapons on civilians that is not limited to direct harm on their life and their health. More often than not, these reverberating or domino effects followed by the destruction or a damage of critical infrastructure multiply the humanitarian impact of the use of explosive weapons in populated areas. Even when civilian structure is not directly targeted in wars, but the attack is launched against a legitimate military objective, infrastructure and services are often either directly impacted from this wide area, these blasts or fragmentations of the weapon used, or they suffer from reverberating or domino effects of the attack. And this is where we see the system collapsing. And this is what we feel that is making the lives of civilians in urban warfare unbearable, in fact. So to summarize, we have deaths, we have injuries, we have psychological trauma, destruction, no or very limited access to healthcare services, no education for children, rubbles instead of homes, displacement, poverty, exclusion. All these effects are a reality of people that are living in urban warfares, and they're creating this humanitarian crisis. So a lot of burden on a political declaration, right? And we want to do what we want to achieve is first that this political declaration should establish a clear presumption against the use of heavy explosive weapons in populated areas. James have mentioned where the wars are right now. They are in children's playgrounds. So we have to stop this practice of the use of heavy explosive weapons in populated areas. Effective change will not be achieved by simply restating the need to comply with existing laws, because this is often what we hear from militaries or from governments, or by relying on existing military policies and procedures, because these are not working anymore because of the nature of conflict has changed. Effective change can be achieved by communicating a clear standalone commitment against the use of heavy explosive weapons in populated areas. Second, a political declaration should recognize the issue of these reverberating or domino effects. The text should be strengthened to include a commitment to ensure foreseeable reverberating effects are considered in planning of military operations. This is something that we don't see enough these days. And third, we want a political declaration to contain a strong commitment to assist victims. And Doctor before me mentioned few elements that why this is extremely important and why this adequate assistance needs to be based on non-discriminatory manner. This is an urgent problem. We can all, I'm sure, agree on this. And it's not going to go away because conflicts are increasingly taking place in urban areas. And on the other side, urbanization is taking its massive growth. So it's not only the current problem, it's a problem of a future perspective. We have been working against a tendency to see this as unfortunate but unavoidable or even normal part of the conflict, falling under a catchy political term such as urban warfare or terrorism even. Instead, we need to work towards seeing this as a distinct humanitarian problem related to combination of weapon technology, so this wide area that I'm mentioning all the time, this physical context, which are populated areas where people go, where people live, where children go to school, where education is happening, where markets are happening. So we have to make sure that there is a strong political declaration that is adopted, hopefully next year in Dublin, and this is the process that has been led by the government of Ireland.
Alma, thank you very much, and I'll come back to that political declaration shortly, but thank you for your thoughts. Michael von Bertele, when it comes to data, you were saying there were still big gaps in data. How much of an impact has COVID unfortunately had on improving that data around paediatric injuries?
But let me digress slightly, because listening to my colleagues speak there, it did remind me of something. What I perhaps should have mentioned at the outset, at the time that Dr. Henson was injured, I was actually the Director General of the Army Medical Services. And I spent 35 years of my life, large parts of it, thinking about the problems of treating soldiers who were injured in conflict. And the military has a very well-tested system that treats casualties from the point of injury all the way through immediate care, evacuation, specialist care, and rehabilitation. And in a sense, that's not what we're trying to recreate in the Paediatric Blast Injury Partnership, but what we are doing is using the knowledge that we have gained. And there are large bits of that journey that we don't understand, and it's different in every conflict setting. And so the field work that we were hoping to do would have involved, had we been successful, training up researchers in different countries, not just doing it ourselves, but trying to get people in the health systems of those countries to do some of the research themselves. And that was quite an ambitious project. And of course, we were going to kickstart it at the beginning of this year in the spring, hopefully with the support of the Rockefeller Institution at their Bellagio Institute. And all of that was put on hold because of COVID. We haven't been able to hold a conference, we haven't been able to get together, we haven't been able to get our stakeholders together. And most importantly, we haven't been able to go to any of the countries that are affected, which is really tragic because we've lost a year. And we know that the challenges have just continued to grow during that period. But just to reiterate, what the military has learned over many, many years has always been put into practice in civilian populations. And what we're trying to do now is not recreate a military treatment system, but identify different points along the treatment system where a small amount of money might make a big difference. And only by doing a full analysis of what's happening at different points on the casualty continuum can we identify where the best place to intervene might be, given that resources will always be limited and given that there will always be huge security challenges in working in these countries.
And Dr. Van Bertele, you were actually in Iraq at the time of the battle for Mosul. What did that teach you about how to handle injuries to children in modern conflict?
Well, sadly, I have to correct you. I wasn't in Iraq, but I was involved in setting up 3 of the trauma hospitals in Iraq that the World Health Organization commissioned from a company that I was working with called Aspen Medical, an Australian healthcare company. So they put in place 3 trauma hospitals 10, 15 kilometers back from the front line around Mosul. And they were an important staging point in the treatment of casualties coming out of Mosul. Mosul was slightly different, A, because it was an urban conflict, B, because there was a relatively sophisticated casualty evacuation chain with first responders, casualty triage points, a series of surgical facilities, and then the ability to evacuate survivors to what we call tertiary hospitals in Erbil. So it was, although not sophisticated, it was a quite well thought out system. And what we saw there in different places was interesting. For a start, generally in conflict, we see a predominance of male casualties. Boys seem to be more likely to get injured than girls. And in and around Mosul, that wasn't quite so stark, probably because these casualties were occurring in the city. People were being injured in their homes, in the places where they worked. And so it was indiscriminate violence. We saw what we would expect, the normal complexity of casualties, but also the importance of putting in place quite simple but well thought through systems to treat those casualties. And it's worth noting that most of the doctors who were working in those facilities, although they were set up independently by a first world provider, most of the clinical staff working in those facilities were local doctors and nurses who had not been able to work. Their hospitals had been destroyed in the conflict. They hadn't been paid. They had no supplies. And so an important part of our job was just putting in place the facilities that allowed local people to come back and work and do the stuff that they were actually very good at.
Yeah, and we were talking actually about the importance of localized healthcare just on the panel yesterday, and to that point, James Denslow, the Pediatric Blast Injury Field Manual is very much aimed at helping people down on the ground in those local areas, the local doctors and nurses and practitioners there. How successful has it been?
Well, I mean, the key thing I think for the manual is that it was requested by medics in Syria who were treating children and were finding themselves without the kind of crutch, if you will, of expertise that a manual like this can help with. And I think the fact that it's gone quite quickly to sort of a dozen countries and quite quickly into now 5 translations is a testament to the need for it. And I think it can go a lot further. I think COVID has unfortunately delayed a lot of things in our lives and taken away lots of the medics who are working on this area of work into treating COVID itself. But there is plans to develop a digital version of the manual. There's plans to, which I think are crucial, to really go beyond medics, because often when these blasts occur, there won't be any form of medic there at the point of injury. So getting resources to zero responders, to non-medical civilians who can then save the lives of children, I think is something that the partnership is committed to doing more. And I think that would be a key next step. And I think I go back to Dr. Henson's introductory line. He said, I shouldn't have survived. And I think what we all want to see coming down the line in the next few years is lots and lots of children saying that they shouldn't have also survived if it wasn't for these kind of initiatives, and then go on to do the amazing things that we know they're capable of. So I think that's where there's a lot of energy and excitement around going next.
And I understand the manual is being published in French and released right about today?
Yes, today is the day we have it. And so today's the day we look to start thinking about its distribution. And we know from some research that we're releasing later this week that amongst the top 10 countries that are the most dangerous place to be a child in conflict. Several of them are French speaking, whether that's Central African Republic, Mali, DRC. So I think it's critically important to have this available in as many languages as possible. And it's thank you to all those involved who got it into French.
Indeed. And David Henson, you talked about the need for multiple prosthetics for children once they have been injured, because obviously they are growing. At Imperial College, what are you working on at the moment? What innovations can you tell us about that will help children growing with prosthetics?
Yes, thanks, Louisa. It's a great question. Children grow, and they grow rapidly. Occasionally children in the UK, for example, might need a prosthetic as many as 4 times in 1 year. In environments where these resources are not available, they're simply left with no option to either use a prosthetic that doesn't fit properly or to not use a prosthetic at all. So it's a key requirement that we develop these prosthetics that are adjustable to enable someone at home, perhaps a parent or a friend, who can use a screwdriver, for example, to adjust these prosthetics to allow them the longevity of these devices to be increased so that the child gets best use out of them. All my fellow panelists here have alluded to the fact that in conflict settings, resources are incredibly limited, particularly in infrastructure. Delivering prosthetic care requires a significant amount of infrastructure, and anything that we can do to reduce the demand on that infrastructure by enabling those people on the ground to deliver some elements of care, the better it's going to be for these children.
Yeah. And your personal experience obviously really plays a large part in this, because you've had to change your whole life around since suffering those injuries back in 2011. And how do those injuries and your experience inform what you bring to your professionalism and your expertise now then?
Yeah, my own personal experiences have completely shaped this, this chapter of my life, which I'm currently living in. From putting on my own prosthetics very early on in 2011 to now in my position as a father. I've got 3 daughters, and understanding the wider context of conflict and what it means to be a civilian player in a conflict zone. It's really shaped the way in which I push this work forward. I just have to look at my daughters and picture them in the settings which I found myself in, and I know that it's not good enough. Your children should be allowed to have a life, should be allowed to access education as and where possible, and everything that we can possibly do to try and provide that should be done. So we're working incredibly hard to try and make these necessary changes to allow children who are most vulnerable, most at need, to get the care that they require.
Very necessary work. Yes, thanks so much, David. And now back to those political efforts behind the scene, because, we need people down on the ground, people working on the medical side, the prosthetic side, but then the political as well. But Alma, of course, it's incredibly important, but if 2 sides are determined to exterminate each other, which is unfortunately the reality of war, how realistic is it that a political declaration is going to really change the dynamics faced by children in conflict zones?
I know exactly what you're thinking. This is a political declaration. It's not even a legally binding document. So how can it make change on the ground, and how it can protect additionally people that should be already protected by very strong laws, what we hear from the militaries and from the governments? Well, I would just say, let's not discourage ourselves by saying that this is a non-legally binding document, non-legally binding instrument, because in the past we have seen very successful political declarations that have changed protection, for example, of education. But I will let this to James, because this is his domain of work, the Safe Schools Declaration. There is a political solution which demands a change of policies and practice, and we have seen it in the past, and we know that for some states political commitment is equally important as a legal commitment. So we are really relying on this fact. The second thing is that with this political declaration, we are not only targeting militaries and government, we are targeting all actors in the conflict. And it has also shown in the past that a lot of legally binding documents, political declaration, have been taken also by non-state armed actors, where they have changed their behavior, like the Mine Ban Treaty, for example, the treaty that is banning landmines or the Convention on Cluster Munitions. So I'm not discouraged. I think this could and will change the future perspective of urban warfare, and it will protect civilians, especially children, in urban warfare.
And James, do you have any thoughts on that then?
Yes, I don't think this is a sort of collection of optimists sort of throwing things into the ether. I think there's evidence around various tracks of work that show that people can make a real difference, states can make a real difference to how modern conflict affects those most vulnerable. The Safe Schools Declaration that Alba mentioned, which was launched in 2015, now has 106 states endorsing it. It was co-launched by Argentina and Norway. And what's very interesting is that in countries that have endorsed the declaration, we're seeing a 50% decline in the military use of schools, while those countries that haven't endorsed it, we're seeing a doubling. So I do think that we have all these instruments of IHL and protection. We have this very practical medical innovation going around the treatment of children who are hurt in conflict. But we also have, I think, a growing momentum behind a political declaration that will have operational reverberating effects in a positive sense. So I do think that all states should get on board with that. And hopefully when that is launched next year in Dublin, and huge kudos to Ireland for leading on this, we have as many states as possible sort of queuing up to get on board.
Okay, so all eyes on next year then. We can hopefully expect that. I do believe there has been a bit of a hold up again because of COVID, as with lots of things, as we were hearing from Dr. Van Bertele as well. But yes, hopefully that declaration next year. Well, I've got a couple of questions from the audience, which I would like to put to you. One has come in from Neil Moores. He says, is mental health a consideration for rehabilitating children who've suffered blast injuries, or does the urgency of those injuries detract from being able to tend those needs fully? Who would like to pick up on that?
I'll jump in just very quickly on that, because I think our mental health and psychosocial experts made sure that if you look at the field manual throughout, we have sections on mental health. So the idea is that mental health doesn't just happen at the point of injury or the point of recovery. There is a point of looking after a child's mental health throughout what can be an incredibly terrifying experience, as you can imagine. So I think we're learning more and more about mental health as a species. And we've certainly learned a huge amount about it when it comes to children in conflict zones. For example, we did some work in Syria looking at how toxic stress, the constant dumping of fight or flight hormones into the child's brain could lead to a very fundamentally different brain architecture over time. So I think it's a really important question, and it's one that the field manual has certainly taken note of, that this is not simply a sort of a physical response that we're looking to look after here. It's also a mental one.
So it is touched upon in the field manual then, mental health.
It's in the DNA of the manual.
Okay, and Dr. Van Bertele, you'd like to jump in there as well?
Yeah, I mean, we're well aware of the impact that conflict has on children, and it is a real problem. But I just want to make one key point. In conflict, and particularly in those countries that have been affected by conflict over many years, there are still a large number of people with existing psychiatric conditions, and their care is always forgotten when we have these conversations, because there are very rarely any psychiatrists or mental health workers left in those countries. So when we talk about the impact of circumstances on people's mental health, we must never forget those who have existing mental health conditions, which are just as prevalent in these countries as they are in this country at all times.
Yeah, thank you very much.
I was going to make a point on the question of the political declaration that we haven't stressed enough. It is true that there has been a much increased focus on the protection of civilians in conflict among all of the, let me call them, the sophisticated military countries of the world. The UK is in the lead in this, along with many of our allies. And we're paying much more attention to the protection of civilians and
slightly losing Dr. Van Bertele then. The line seems to have been dropped there. Would anyone like to pick up then? We were talking again about that political declaration. Anybody got any additional thoughts on that? Otherwise, I wanted to go back, James, to the manual, which is getting a lot of interest in this panel discussion. And we were talking about the fact that it touches then on the mental health. But do you see gaps in knowledge in the manual that could be addressed in subsequent editions? And that's a question that's come in from the audience.
Yes, certainly. And I think this is not an attempt to proclaim ultimate knowledge on a new topic. I think what it's done is establish that it is a topic and that it is one that there is interest and there is research and operational response around it. So I think the biggest single lesson of the partnership so far is that this is a huge, huge problem. And it's not one that we can solve or respond to adequately ourselves, whether as agencies or academics. So we're constantly only as good as the sum of our parts. And I would encourage anyone who has any expertise to bring to this or any ideas to bring to this to really let us know as conveners of it, because this is not a problem that will be solved by Imperial College and Save the Children. It needs, as I said earlier, a community of concern that goes far, far wider than that.
Thank you. And another audience question on the manual, James. How effective is the French paediatric response manual in comparison to traditional mechanisms of emergency response?
Well, I guess the question would be which traditional mechanisms are we alluding to here? I think the manual is it's not new medicine. It's not introducing sort of new techniques as such. What it is bringing together in a helpful and navigable form. And I'm speaking now, trying to channel my inner Dr. Paul Reevely, who's the lead author, is something that in the middle of an emergency, a non-pediatric specialist can go to and help give them the confidence to be able to treat this child, which is very much the kind of problem statement we got from Syrian medics and the response from other medics involved. So I don't think, again, it's necessarily revolutionary in itself as a manual. I think where it is revolutionary perhaps is by sort of really establishing that pediatric blast injury is a concept in and of itself.
Okay, James Denso, thank you very much. David, unfortunately, we are running out of time, so I'm so sorry that you won't be able to jump in with any more thoughts, but thank you so much. And you know, this has been really interesting to hear that there are still gaps in the knowledge and the data, and more research needs to be done. But I think a general consensus that a two-pronged approach is needed. You need that practical action on the ground, the local information, practical information that people and responders need when children are injured, but also that policy change at a national and international level to better protect children from harm. So thank you to our panel today, Dr. David Henson from Imperial College London, Dr. Michael van Bertele from the University of Southampton, Alma Al-Oster from Humanity and Inclusion, and James Denso from Save the Children. Thank you very much indeed. I will be here again tomorrow for another In Focus panel. I hope you can join me then. Thank you. Goodbye.
Thank you, Louisa.